Okay, I'll get started so Jen can get her presentation started. If anybody comes in, straggles in, that's great. I'm Gwen Pryor. A few of you know me. I'm the LAM liaison for Michigan, and I also have TSC and LAM. And I do have evaluation forms. That's what I was thinking of, that you can fill out. The session's titled Genetics in LAM and TSC. Jennifer Glass is going to do our presentation. She is the genetics counselor for Cincinnati Children's Hospital. She got her bachelor's degree in genetics at Purdue, and then her genetic counseling master's at Case Western Reserve University. She's worked at Cincinnati Children's since that time, where she's the genetic counselor for the tuberous sclerosis clinic. Over the years, she's developed an expertise in tuberous sclerosis genetics, and she now serves on the professional advisory board for the TS Alliance. I have been to Cincinnati for several years. This is the first time I've had the pleasure of meeting Jennifer. So our names have crossed paths, but this is the first time we've actually met each other. Yes. Yeah. So, well, welcome to Jennifer. Glad to have you give us your presentation.
Hey, everybody. So I tried to put this talk together kind of starting from a pretty basic level, but certainly, especially since we've got a small crowd, if you have questions, if things come up as I'm going along that don't make sense to you, raise your hand, shout out. I'm happy to go back over things or address things that I'm not talking about, okay? Okay. Okay, so I said I was going to start basic. All organisms, including humans, are made up of millions and millions of cells. They're what make up all of our different organ systems. And the instructions that tell those cells what to be and what to do are within our chromosomes, which contain all of our genes. All of our genes come in pairs. You get one set from your mom and one set from your dad, so you should have 2 copies of each of your genes. And genes have a quote-unquote normal or reference sequence. And really that is just the most common sequence that is out there. Anything that is different from that quote-unquote normal sequence is called a variant. And there's been a move among the genetics community to start talking about all of those changes as variants. Rather than using the word mutation. I use both of them in my talk just because old habits die hard. But we're moving more towards language around variants because really there are many different types of changes or variants that can happen in a gene. And some of them don't cause any problems at all. So there are some changes within a gene that don't affect how that gene actually functions. And we call those benign variants or silent variants that don't cause any problems. And then there are what we think of as the classic mutations, which are those changes that cause a gene to not function properly. And the tricky part is sometimes there are changes in those genes that we don't know whether they're benign or whether they're disease-causing and pathogenic because we just haven't seen them frequently enough. And they're a small enough change that we just can't tell for sure. Another important concept, especially for this group, is something called mosaicism. When we think of typical, quote-unquote, genetic disorders, so inherited disorders, Mendelian disorders, like tuberous sclerosis, we think about that person having their mutation or pathogenic variant in every single one of their cells. That is the typical way that people have TSC. However, we also know that in TSC and other genetic disorders, some people have what we call mosaicism. And mosaicism is something that instead of having that initial mutation either in that egg cell or in that sperm cell or happening in those very early stages, at some later point in embryonic development or later in life, an individual cell can develop a sporadic mutation. Our cells develop mutations all the time. It's how evolution works, right? Most of those mutations don't cause any problems. Either they are benign and they don't do anything, or they're so bad that that cell just dies automatically and nothing ever turns of it. But these mutations can happen all the time in all of our genes. And so when a mutation happens later in development, all of the cells that derive from that one specific cell are going to also have that mutation or that pathogenic variant, while all the rest of the cells will not. And that's how you can wind up with people that have a mixture of some cells with TSC and some cells without TSC. And sometimes that percentage can be fairly consistent. Say you've got 60% of your cells that have TSC and 40% don't, and that's consistent in all of your organ systems. Then there are some people that have what we call tissue-limited mosaicism, where it is limited to just within, say, the lungs. This is where we get into sporadic LAM, okay? When that mosaicism is limited to a specific organ system, then we can see things like isolated LAM, isolated cardiac rhabdomyomas, things like that, okay? And there are two genes that we talk about in both sporadic LAM and in tuberous sclerosis. They're called TSC1 and 2, because it's easy to remember. TSC1 is located on chromosome 9 there. Again, we've got 2 copies of all of our genes, 2 copies of all of our chromosomes. And then TSC2 is on chromosome 16 there. And the reason that 2 different genes are involved in the same disorders is that those 2 genes work together when they are working in the cell. So TSC1 creates a protein called hamartin, and TSC2 creates a protein called tuberin. And hamartin and tuberin bind together to create what's called the tuberous sclerosis complex. And that complex does all of the work within the cell. So you can have a mutation that causes either one of those proteins to not function properly, and it results in the same thing because they work together within the cell. And the work that they do within the cell is inhibiting mTOR. And mTOR is the kind of master switch for cell growth. And I have a nice little analogy to think about this. So TSC1 and 2 are what we call tumor suppressor genes. Their job in a cell is to prevent a cell from turning into a tumor. If we think about a cell like a car, when it's on a level surface, it is going to mostly stay there and not do anything. If we think about that car moving forward, that would be turning into a tumor. If it's on a level surface, there's no reason to do that. But cells naturally have mTOR within them, and that mTOR is like putting that car on a hill. That mTOR is a naturally occurring substance that is going to make that cell want to turn into a tumor. Our cells have a backup to that, which is the TSC complex. That's the brakes on your car. That's going to keep that cell from rolling down that hill. And because all our genes come in pairs, we've got 2 brakes. Okay, we have our gas brake and our emergency brake, and both of those are keeping that car from rolling down the hill. People with TSC are born with one of those brakes not working properly. And in most of their cells, that's okay, because they've still got their other copy that is working properly, and that cell is not going to turn into a tumor. However, if that person develops a second mutation randomly, all of a sudden you have no brakes and you have nothing to keep you from rolling down that hill, and that cell is going to turn into a tumor, okay? By the same token, if you have somebody who doesn't have TSC, but they have a cell that randomly gets a mutation, and then at some point later in their life, that same cell randomly gets another mutation, they're also in that same boat. That's why people without TSC can have LAM, but why people with TSC are so much more predisposed to it. Okay, this all making sense? All right, this is also why mTOR inhibitors work for both sporadic LAM and for TSC, and why they work for so many different symptoms within TSC. Because the mTOR inhibitors are actually working at the mechanistic level, at the ways that the cells turn into tumors, and that works for all of the different tumor types. Okay? Okay, so this is, sometimes I hear people talking about, oh, my TSC is genetic, or no, it's not. all TSC is genetic because it's all caused by pathogenic changes or mutations in those two genes. It's all genetic. Usually what people actually mean is sometimes TSC is inherited from a parent, and that's true of 1/3 of people with TSC. And sometimes TSC is sporadic. It just pops up new in a person, and that's actually more common. 2/3 of people that have TSC, it just popped up new in them. By the same token, LAM is also genetic. It's caused by pathogenic changes in those same genes, TSC1 and 2. The main difference here is that if it is truly sporadic LAM, it is not inherited. Okay? So, for people that have some suspicion of TSC, whether it's because they have LAM or they have a cardiac rhabdo or they have seizures or whatever, people that have some suspicion of TSC but do not meet clinical diagnostic criteria, what can we do to try to figure out if they have full-blown TSC or if they just have this one symptom? One of the first things that we do is take a medical history. Pretty straightforward. Sit down. Have you ever had seizures? Have you ever had learning problems? Have you ever had any weird skin findings that had to be removed? Taking a history can certainly sometimes clear things up. Sometimes I'm talking to, I've got a kid in front of me who has TSC, and I start talking to the parents, and oh yeah, I had seizures when I was a kid. They didn't think anything about it. Oh yeah, I had this as a kid. They didn't think anything about it. By the same token, family history. So does somebody else in your family have TSC? That's going to be a big red flag. But also, oh yeah, my mom is older and she had seizures, but she passed away years ago. Nobody really knew what it was. We can hear some of these suspicious things that kind of start to come together and can make us more suspicious of TSC. Physical exams are really important, and having a physical exam done by somebody who is familiar with TSC, specifically the skin manifestations. Skin manifestations are incredibly common in tuberous sclerosis, and so having a skin exam that looks at the nail beds and looks really closely at the skin all over, uses a black light to look for white spots on the skin, which is particularly important in very fair-skinned people because those white spots can hide. Looking for facial angiofibromas. I have patients who come in and we talk to them and notice that they have facial angiofibromas and say, hey, I see these bumps on your nose. Have those always been there? And they're like, oh yeah, I thought it was acne. No, it's not acne. It's there all the time in the same spot. Those are facial angiofibromas. So those physical exams can be really important. Eye exams, dental exams. Those are all non-invasive exams that can be done. Most of these symptoms aren't really talked about a whole lot because skin findings, the dental findings, the eye findings, they don't actually cause that many problems. So you don't hear people talk about them a lot, but they can be very, very helpful for diagnostics. One of the biggest hitters is imaging. So that's going to be your echocardiograms in little babies. It's going to be your brain MRIs, your kidney MRIs, potentially chest CTs. Those are all going to really look into the places that we commonly see symptoms. They are more expensive. In little kids, you have to knock them out. So we don't like to do them willy-nilly, but they can be really, really helpful for diagnostics. And then the last piece of that puzzle is genetic testing. And I'm going to talk a little bit more about the genetic testing in a little bit. But the important thing that I want to talk about here is none of these pieces individually is going to be able to tell you if you have TSC or not. Even all of them together may not be 100% certain. In genetics, there's a common running joke. There are two numbers a geneticist never uses, 0% and 100%, because I've seen the exceptions, and so I never use those numbers anymore. I've never had any symptoms of TSC ever in my entire life, and I can't be 100% certain that I don't have it. What we can do is compile more and more information so that we can be more confident that somebody does or does not have TSC. Okay? The reason this is so tricky is because TSC is so variable. In just about every genetic disorder out there, we talk about that there is going to be individual variation. So if you think about a common disorder like, say, Down syndrome, yes, there's going to be some variability between what one person can do and what another person can do. But at the same time, you have a pretty general idea of the kinds of issues somebody is likely to have. In TSC, we don't have much generalities. We know the things to look for, we know how to screen for them, and we know to some degree what those prevalences are, but we see such a huge variability from people who have almost no symptoms, no outward symptoms whatsoever, to people that have very many and severe symptoms. It can make it really tricky when we're trying to figure things out, but it also keeps us on our toes and keeps it interesting. One important thing to point out is we do see this variability both between families and among different members within the same family, all of whom have TSC. So we have some families that multiple people in the family have TSC and everybody is very mild and about at the same level. Or we have families that the only symptom that everybody in the family has is, say, cardiac rhabdomyomas. But we also have families where one person is very mild and another person is very severe, and then a third person is somewhere in the middle. So we know that there's more to the variability than just the specific genetic change, because everybody in a family who has TSC is going to have the exact same genetic change. And we can actually even see that when we look at identical twins. There are about 5 sets of identical twins I know of in clinic and another 8 or so in the medical literature. And about half of them are significantly different in their level of symptoms, in at least some of their different symptoms. And they have not only the same TSC pathogenic variant, but they've got all the rest of their genes the same too. So we know that there's more to severity than just the genetics, okay? One of the questions that I often get is, what's the difference between TSC 1 and 2? If you look in the literature, there are some differences in the risks for certain symptoms, LAM being one of them. We know that the risk for LAM is more common in TSC 2 than in TSC 1. However, we see a great deal of variability within both of the genes. And so at this point, we don't actually treat people different based on on which gene their pathogenic variant happens to be in. We screen people for all of these things. At some point, we may be able to limit some of that once we get more confident in saying this specific change does not have a risk for this specific symptom, so we don't need to screen for it. But at this point, that is very much the minority of cases. There's one very specific difference to that, and that is there's a minority of people who have tuberous sclerosis related to a deletion that includes both the tuberous sclerosis, the TSC2 gene, and the gene right next to it, which is called the PKD1 gene. People that have a deletion of both of those genes have both TSC and polycystic kidney disease, and those people are at a very high risk for severe kidney cysts and problems. And so those people we do have on a separate management. We're very aggressive with their kidney management because they are at such a high risk. So this is kind of our one exception to treat. We do treat people differently when we see this. Yeah. Yes, this is, so PKD1 is specifically related to the cystic disease. And it's a little bit tricky because you can get cystic disease just in regular TSC. But we think of this kind of thing when we're looking at like hundreds of cysts in small children, okay? It's a pretty significant difference. Okay, so I said I was going to talk about the genetic testing. I'm going to get back to that now. For a long time, there was a particular company called Athena Diagnostics, and they had a patent on the TSC2 gene. They were the only lab in the country that could do the testing. They started off offering sequencing of TSC1 and TSC2. Over the years, they then started offering deletion analysis of TSC2, and then later deletion analysis of TSC1. In 2013, there was a Supreme Court decision that said that it's illegal to patent a gene, and so Athena no longer had sole rights to that testing, and very shortly thereafter, actually even slightly before the Supreme Court decision came out, a number of other labs, first Prevention Genetics and then GeneDx, and then a whole host of other labs started to offer genetic testing. Now there are dozens of labs out there that offer it. There are some differences between labs related to both pricing and the thoroughness of the testing. They should all be offering sequencing of both of the genes and deletion analysis of both of the genes. The biggest difference in kind of the quality of testing right now is the ability to detect low-level mosaicism. You really have to do what's called a high-depth read, which means when you're doing your sequencing, you do it over and over and over again. And you have to do that a great number of times to be able to pick up low-level mosaicism. And so that is one thing that I do try to pay attention to when I'm choosing labs. So the detection rate of the testing is not perfect. It is about 85, it might be up to closer to 90% now with the labs that are doing that high-depth sequencing. But that still means, even if we're up to 90%, that still means that 10% of people who definitely have TSC, meet clinical diagnostic criteria, they're still going to have negative testing, not because they don't have a variant in TSC1 or 2, but because our technology just isn't good enough to find their particular variant. Our technology is getting better and better. Over the years, that detection rate, it started off about 70%, and it's gone up and up over the years. It will continue to go up as we learn more about these genes and as our testing gets better. But the important thing about that is that this testing is not a 100% answer. Again, it's just going to make us more or less likely to think about TSC. So results, when you get genetic testing back, you can get a positive. That means we found a clear-cut pathogenic variant in TSC. You have TSC, you have a 50% chance of passing it down to any child. You should be screened for all of the various complications for TSC. You can get a negative, which means we didn't find anything. It is less likely that you have TSC unless you already had a clinical diagnosis. And it more likely means that you don't have TSC, or it means you have a change that we just can't find with our technology. And then the last option is called a variant of unknown significance. And those are kind of the bane of my existence because we find them and we say, we just can't tell whether it's the type of change that is going to be pathogenic and cause TSC, or if it's a benign change that isn't really affecting how that protein functions. There are some things we can do about that. If we have a child who has TSC and their parents don't appear to have TSC, we can test the parents. And if neither of those parents has that change, that means the change popped up new in the child, the symptoms popped up new in the child, therefore it's more likely that those two things are related. On the other hand, if we test parents and, hey, it turns out dad has this, maybe we look a little bit more closely at dad. We do some more in-depth exams. Maybe we do a brain MRI. And if it's all negative, and we can be pretty darn confident that that dad does not have TSC, then we say, okay, this is likely a benign change that is not causing TSC, because if it was going to, it would cause it in dad as well. Okay? So, recurrence risk. One of the reasons that people do genetic testing and kind of pursue figuring out whether or not they have TSC often is because of the recurrence risk. We know that for people that have TSC, the chance to pass TSC down to their child is 50-50. And that is a random coin flip each time. It's kind of like the chance you're going to have a boy versus a girl. We all know those families that have 4 kids and they have 2 boys and 2 girls, but we also probably know those families that have 4 boys or have all 4 girls. So, you know, things like birth order, having a previous kid that had or didn't have it, none of that affects it. It's a new risk for each pregnancy. On the other end of the spectrum, the general population risk for TSC is 1 in 6,000. So we know that absolutely anybody can have a kid with TSC. And I always think that it's important to point that out, because even if we do all the screening that we can, sometimes randomness in Mother Nature can throw wrenches in our plans. And then here in the middle, we have people with mosaic TSC. And when that mosaicism extends to the germ cells, aka the sperm or egg cells, it can depend on what level mosaicism is in those germ cells. And that can be very, very difficult to determine. In fact, clinically, we usually can't. So in practice, for people that are mosaic TSC, we treat them as their risk being up to 50%, because we don't know exactly where they might be in between those two. So people that have truly sporadic LAM, that is limited to just their lungs, they're going to be down at that general population risk. People that have full-blown TSC are going to be up at that 50-50. And people who have a known mosaicism are going to be in that middle ground. Yeah.
I just said I have sporadic LAM, but I had an AML during my pregnancy.
Okay.
And I've just been told I just have TSC tendencies. Could it not show on a brain? Would it be worth it to do genetic testing, or does it really even matter?
So brain MRIs are pretty diagnostic. The large majority of people with TSC are going to have something that shows up on a brain MRI. It's one of the most kind of the heaviest hitters of our different tests that we can use to look at somebody. And so a lot of that really comes down to kind of your own concern. The genetic testing isn't going to be 100% either. It could add a further layer of confirmation that you don't have TSC, but it's never going to be able to completely rule it out one way or the other. So certainly it's not something that we say that everybody who has any symptom of TSC needs to have genetic testing. No, I don't think that's necessary. But I also talk to parents who their other kid is at a very low risk, a 1% risk for TSC, just because they have a sibling with it, but it's keeping them up at night. Every time their kid twitches or does this little thing, they worry. Or I have people who are worried about themselves. Every time they get a migraine, every time they, forget something, they're worried, could this be TSC? And in those cases, sometimes having another layer of assurance that we've also had genetic testing that was negative, sometimes that can be beneficial. So a lot of it kind of can depend on your personal anxiety level as to how worried you are about that risk. Any questions? Okay, so I'm going to try to go through this last round of the slides fairly quickly because they are more so focused on people that do have TSC. And they go over some of the different family planning options that are available to people that have TSC who are at that 50-50 recurrence risk. And I'm going to go through each of these. So non-biologic options are a great option for people who are interested in having children but don't want to take a risk of passing TSC on to their children. The ones that people usually think about are adoption, and there are lots of different options kind of within that adoption field. But then there are also options for things like egg donation, sperm donation, embryo donation. All of those are not going to completely eliminate the risk of TSC because if you remember back, that general population is still going to be a 1 in 6,000 risk, but it's going to turn your risk into the same as anybody else's walking down the street. There are some people that they know the risk is 50-50 and just choose to go about things kind of the old-fashioned way. with traditional conception, pregnancy. There are some screening options we can offer to people whose pregnancy is at a 50-50 risk to have TSC. Those include a fetal echocardiogram, which is just an ultrasound looking very, very closely at the baby's heart in utero. And over the last few years here at Cincinnati Children's, we've started offering fetal MRIs to our patients. We do this a little bit later in pregnancy. And specifically, we're looking at the brain and the kidneys. And we have had several cases that we were able to diagnose prenatally based on these MRIs. The other really nice thing is if we can get really good imaging on a fetal MRI, sometimes we can delay the need for doing an MRI. Rather than needing to do it right after birth, we can delay that by a while. And because that is associated with a sedation, that's often nice to be able to kind of wait till the baby's a little bit older to be able to do that. But we do always recommend an evaluation after birth and EEGs very shortly, within 6 weeks after birth. Okay, so there are another two options for prenatal testing. Both of these, we have to know the specific pathogenic variant or mutation that the parent, that is causing TSC in the parent. If we know that, a CVS is a procedure that goes through the vagina, through the cervix, and gets a small sample of the chorion, which is what turns into the placenta. The baby and the placenta share the same DNA, and so we can test that sample for the known mutation in the parent. Both this risk and the next one I'm going to talk about are invasive procedures, so they are associated with a small risk for miscarriage. The risk for CVS is physician dependent, but it's usually about 1% to 0.5%. Amnio is done later in pregnancy, so the CVS is done at the end of the first trimester. The amnio is done after 15 weeks, which is into the second trimester. The risks are lower, probably about 1 in 500, 1 in 800, something like that. And this procedure, you may have heard of, basically, needle goes through mom's belly into the fluid that the baby's floating around in. There are cells that have sloughed off baby's skin in that fluid. We can get those cells out, culture them up, and then test them for the specific mutation in the parent. There's also an option called pre-implantation genetic diagnosis, or PGD. And this is a process that uses in vitro fertilization. Basically, you get eggs from mom, you get sperm from dad, you mix them together, you create a whole bunch of embryos. You can then take a teeny tiny biopsy from each individual embryo and test that biopsy for the mutation found in the parent, and then you only implant the embryos that do not have TSC. And this has been used in many patients with TSC as a way to get pregnant. But it is expensive. The IVF is honestly the expensive part of it. And it's complicated. You have to take hormones, you have to go to all these appointments. All these options kind of come with pros and cons. There's no real easy answer to a lot of this. But I have to say, over the years working with people, I have seen people choose each and every one of these options, and to a person, what they choose is right for them. Different people are going to choose different things because they have different priorities, they have different values, they have different concerns and levels of anxiety. But there is an option out there for everybody. One more thing that I do like to talk about, and this is relevant to both sporadic LAM and to patients with TSC, is that there are some medical concerns that should be taken into consideration before getting pregnant. So if you're a woman who has LAM or who has TSC, I always encourage you to talk to your doctors if you're interested in getting pregnant, just to make sure that your organs and that your body is healthy enough to go through pregnancy. Most women with TSC can get through pregnancy perfectly fine and have perfectly healthy pregnancies. But we do know that the hormones associated with pregnancy, we all know hormones kind of go crazy during pregnancy, and those hormone levels can exacerbate symptoms of LAM or kidney AMLs. We do not generally see a woman who is totally healthy, not having any LAM problems, not having any kidney AMLs, go through a pregnancy, and all of a sudden they're doing horribly and, need a transplant. We don't see that. What we can see is people that are already having issues, usually significant issues with either one of those organs. Pregnancy can just make those symptoms get worse faster, okay? So we always like to check in, make sure we have recent imaging, make sure we have recent VEGF-Ds, all that sort of stuff before you get the all clear to start trying. The other thing to take into consideration is medications. People that have TSC, if you're on seizure medications, many of those are not recommended during pregnancy. There are other medications that are. Oftentimes our doctors can switch people over safely to another medication that they can use to control seizures throughout their pregnancy. The other big one for both groups of sporadic LAM and TSC is mTOR inhibitors. mTOR inhibitors are not recommended during pregnancy, and so they should be stopped prior to starting to try to get pregnant. So I work at Cincinnati Children's Hospital. We see patients from fetal through, I think our oldest patient is 87. So I'm there every Wednesday. But I know that many people don't live near here. There are genetic counselors throughout the country who can talk to people about genetics of TSC, talk about family planning options, order genetic testing, interpret genetic testing, all of those things. NSGC is the National Society of Genetic Counselors. They've got a great page where you can go in, type in your zip code, and find a genetic counselor nearby you if people are interested in talking about that more. I just want to thank everybody over at the TSC clinic. We do a summer camp for kids ages 8 to 18 who have TSC. It is free to the patient, and we have an absolute ball. The kids get to go out to a camp when many of them have medications or seizures that prohibit them from going to most regular camps. The kids get to go to camp, parents get a break, and the providers get to spend some time with the kids just having fun rather than sitting in an exam room and talking about all the problems. So it's really a win-win-win. I'm really lucky to work in the TSC clinic at Cincinnati Children's. We have a fantastic team where everybody really is experts in their own area and trusts everybody else and works together really, really well. So I wanted to thank my team and see what questions people have.
Try to not make it a loaded question. So
ahead.
I have TSC, and I am currently going through perimenopause.
Okay.
And I have little, I call them like little rashes, but like little bumps on my stomach.
Okay.
And one of the things I notice is like around the normal time of menses, which I haven't had in a long time, it's like they get
flare
more
up?
prevalent. Yeah, they flare up, and I'm like, but then they kind of subside, and I'm like, I don't know if it's in my head, but
No, it's not in your head. It's hormone related.
Okay.
So
that was my question.
yes,
Thank you.
Yes, it absolutely is. So a lot of the skin manifestations of TSC you're going to have from birth, but we often will see flare-ups at two big times: puberty and menopause. And it is directly related to those hormonal issues. And really the hormones, it's the same reason that hormones affect LAM, right? It's all related to each other. Yep.
I just had a question when you said about the gene variants. So that can happen if it doesn't happen between the egg and the sperm. So you can be born without a variant?
So you mean and have TSC?
No, and have, for it to change later, yes. So if there's going to be a variant, so I'm sporadic LAM.
Okay.
I guess my question is, obviously I had a variant somewhere. It could have happened anytime, because you said later in life, and that's what I was trying to clarify.
Yeah, so sometimes when we think about mosaic TSC, we think about people that have some cells without TSC, some cells with TSC, but they've got that, in several different organ systems. When we think of, and we typically think that happens sometime in embryonic life, so after cells, so you've got your ball of cells, right? And a big chunk of those cells are going to go off and turn into the placenta. So if you have a mutation there, it doesn't matter because your placenta is going to get thrown away, right? So we know it's sometime after that division, but it's sometime early on where cells are still spreading out to various places. When the mutations are limited to a specific organ, we know that at a bare minimum, it had to happen after all of your cells that were going to turn into that particular type of organ had all differentiated themselves. What we don't know is if that happened at that point in embryonic life or later in life. Because for sporadic LAM, it can happen later in life. Yes, yes. Yeah, so you can have a variant and it can just start in one cell, but it can then propagate into other cells, especially once it starts once you get that second hit and it turns into a tumor, it can spread with a similar mechanism to cancer. Even though it's not cancerous, it uses a similar mechanism to spread.
I'm sorry, I came a little bit late, so you may
No,
have
you're all
addressed
right.
this, but to further on the sporadic part, are you hopeful that, I'm in a genome study at NIH,
Uh-huh.
will that help benefit you as far as where we really determine where it may or may not have happened, or what information should that, I don't really know how much it'll spread,
Yep.
will help you?
So there are a lot of different things that we can look at. So when a genome study is basically trying to read through every single nucleic acid base pair of your DNA to see what is different than the quote unquote normal sequence, okay? The only two genes that we know that cause TSC and sporadic LAM are TSC1 and 2. For a while there was some talk about could there be a TSC3, but pretty much everybody agrees that's not the case now. However, we suspect there are likely other genes that interact with TSC1 and 2 that may do things like influence severity of symptoms, influence which symptoms present, influence how well somebody responds to medication, influence the progression of the disorder. So we know that there are a lot of other genetic factors that we don't understand yet. And that's a lot of what genome studies are looking at, is kind of those other surrounding factors, okay? We also in our clinical genetic testing, which is mostly looking at the exons. So our genes, we have these really long sequences of genes, and they're broken up to two main parts. They're called exons and introns. The exons are all spliced together to make the proteins, and the introns just kind of get spliced off and lost out in the cellular matrix. To be perfectly honest, we don't have a great understanding of what those introns do. As we're learning more and more about TSC specifically and genetics in general, we're learning that changes in those introns actually can make a difference. And so a lot of the genome research is looking at those areas that we previously have ignored and seeing are there changes there that can affect things in ways that we don't really understand yet. But I think that is going to be a key to some of those people in that 10% who we know have TSC, but we still can't find their variant. That's probably where a lot of those are hiding.
Jennifer, can you address too if TSC1 or TSC2 is more severe?
Okay, so really common question, thank you. This most commonly comes up. I have a kid that shows up in my clinic that has TSC, and the parents want to do the genetic testing, and they are really hoping for TSC1 because they've read all over the internet that TSC1 is the mild one and that TSC2 is the severe one. And what I like to say is, technically that's true. There's been studies done out there looking at things like frequency of seizures, looking at tuber burden, looking at risk of LAM, things like that. And yes, those risks do tend to be higher among people that have mutations in TSC2 versus TSC1. However, we see people with mild symptoms, with almost no symptoms with TSC2 mutations. By the same token, we see people with TSC1 mutations who have very, very severe symptoms. So if I say to you, your risk is going to change from, a risk of seizures of 80% to 85%, does that really make a difference to that parent? I kind of tend to think about it. If you had a room of 100 people with TSC1 mutations and a room of 100 people with TSC2 mutations, and you walked into both of them, you could probably guess which room you're in. If I have one person in one room and one person in another room, there's no way to tell which one it is. So while there are some technical differences that you can find when you do very large cohort studies, when you're looking at averages over large groups of people, I don't find that actually to be very useful when I am talking to an individual person, because we still see that variability within both. Thanks for coming, everybody, and hanging out for the last talk of the day.